You're listening to Streetside, a Street Medicine Institute podcast.
Hello, and thank you for tuning in to Streetside. We are excited to welcome back to our program our host, Poyani Bavishi. Poyani was a medical student when she launched this podcast in 2023, and she is now finishing her residency program in psychiatry at Montefiore Einstein and was able to interview Dr. Andrea Littleton. Dr. Littleton is the medical director at BronxWorks, the faculty advisor for the Homeless Outreach Project at Montefiore Einstein College of Medicine, and she is also the faculty leader for the homeless track of the Family Medicine Residency Program. Welcome, Poyani and Dr. Littleton.
Thank you so much for coming on the podcast, Dr. Littleton. I have been so incredibly to learn about your work in the Bronx, and I'm really excited to hear more about your story. Having been at this residency and getting to see the social medicine program, I can tell the incredible passion that residents have, and to see how that goes later down the line and to see what you've done with it has been incredibly inspiring to me.
Oh, thank you. Thank you so much. And thank you so much for having me. I was very honored when you and Ryan asked me to talk about the work I do. It's something I have a strong passion for and love to talk about.
I would love to start off with maybe where in your journey you found street medicine or what inspired you to join this work, if there was a moment.
Yeah, certainly. I mean, I have always kind of valued I always knew I wanted to do family medicine. I always knew I wanted to kind of look at holistic care and not just treat the person, but treat like all of the things that go on in their life, like all the social determinants of health and how that affects people's health. So like it was funny, when I applied for residency, I only picked Montefiore and I ranked my programs. And it was funny because I was in Mexico at the time doing like this like Spanish medicine elective. And I was like, if I don't rank, I'm going to be in trouble if I have to try to struggle and find another program. But I was lucky I did. And I really wanted Montefiore because it was the only residency program. It was the Montefiore Family Medicine program in social medicine. And it really was the only one that really valued and exemplified that it was going to train doctors to talk about the social determinants of health and really try to treat the whole person. And that was something that I thought that was really important to me. I was at Montefiore doing my family medicine residency and really didn't know what part of family medicine I wanted to do, but I was really fortunate my third year to have a rotation with Matt Anderson, who was the medical director for the Bronx Care for the Homeless team. I hadn't really heard about the homeless work prior to that. He was wonderful and kind of showed me all the different settings that they practice medicine in various clinics throughout the Bronx. He at the time was the medical director for the Bronx team of the Care for the Homeless. At the end of my residency, he was kind of like, Andrea, I'm doing a lot of other research and other stuff. And do you want to like take over this work? And I was like so excited and enthused to be able to do that. Although I was slightly daunted because I was like, I can't be the medical director of anything. I'm like, I just graduated residency. I know nothing. He was like, don't worry. This Debbie Barrow, she's the nurse practitioner. She pretty much runs the program. You just kind of like oversee and like go, check in on people and see how they're doing at the various sites. So that's kind of what first immersed me in kind of doing homeless healthcare. And I loved it. I really at that time as like the medical director got to work in various different clinics, in drop-in shelters, in intake shelters, in soup kitchens, and in various different arenas. And I loved it. And I learned a lot from Debbie Barrow, the nurse practitioner who like ran the program. And at the time, she was actually the one who was doing the street medicine. So like she kind of told me about it and I was like, oh, this is fascinating. And I would start going out with her. And then unfortunately about in 2010, Montefiore and Care for the Homeless kind of split. And when they separated, most of the nurses and other people on the team kind of stayed with Montefiore. But I really enjoyed the work I was doing. I had already kind of incorporated having residents and students come out with me. So I was like, I really want to stay on. And so at that time, they were like, okay, well, where do you want to be? And I was like, well, I want to take over the street outreach and I want to work at the living room, which is the drop-in shelter. So that's where I've been ever since. And it was really been a passion of mine because it really kind of put all of the things I enjoy doing in medicine into play in terms of trying to care for people who are really struggling living outdoors.
What an incredible journey. I find it always striking to hear about kind of the first contact or two contacts that kind of inspire you and set you on this path that I think a lot of people don't really maybe initially see themselves going on. It's so beautiful to hear about those people. And also to be offered a job of a medical director kind of right out of residency. I'm picturing that for myself, and I think there'd be all kinds of thoughts going through my head. What was that process like for you?
Yeah, it was totally daunting. I think the thing that I almost said no until I met Debbie Barrow, who was the nurse practitioner, and she really ran the program. To be quite honest, she taught me like a lot of what I know, right? And I really knew I could learn a lot from her. And I think that I understood that like it's a team aspect to the role of the, running of the program. And my decision alone was not paramount. And so she really kind of helped guide me in doing the work that I did.
Absolutely. So it sounds like, well, from your story, from only applying to Montefiore, it sounds like this is something, at least some part of you had that mission from even in med school.
Yeah.
I'm wondering if there is like a part of your identity or background that you feel like drew you to this work specifically?
I think my background, my both of my parents, we didn't really have anyone in medicine. Both my parents were teachers. They are from the South. They're from Arkansas, kind of came up to New York to find work. Really down to earth people who kind of understand the value of community and the value of everyone to bringing people's health and wellness. And so I think when I decided I wanted to go into medicine, I knew it would be from that lens and know that like it was important for me to try to treat people as people and all the things that go on in someone's lives that may affect their health. At being people of color, like my parents kind of would always talk to us about all of the obstacles and barriers to not just health, but to just getting housing, getting a job, getting, so many things that unfortunately people of color are vulnerable to. And I knew it was just really important to me when I had this opportunity to be in medicine to try to help, help people of color and people who are underserved to get better access to wellness. And so that was really an important role I felt I could play as a physician. And so I was really wanting to see what avenue I could pursue that when ultimately I got that degree.
Absolutely. And I feel like the aspect of teaching and being inspired by teachers, like, it's such a large part of medicine.
Yeah.
And sometimes we acknowledge it and make space for it. And other times I feel like we might not be the best at that aspect of teaching.
Yeah, no, for sure. Like, it was funny because I never really thought like I would be a teacher, right? In that sense. And it's neat to be able to see how my path has led me to not only be able to practice medicine in the way I like, but also be able to help learners do the same.
So I'm curious, it sounds like a decent amount of your work has been in New York. I'm wondering what factors of street medicine logistically are specific to the system in New York, whether that's challenges or maybe some of the benefits of the resources in New York that you feel like make street medicine run specifically here.
Yeah, I mean, New York City is an amazing city in so many aspects, but very daunting in so many others, right? I feel like we have so many people in New York City, but I think some of our strengths are also our weakness, right? And because there are so many people, we really don't have enough housing, right, to provide to all those individuals. And affordability of housing is I think the biggest barrier in why so many people are homeless in our city. I think it's difficult because we are so large. We have so many teams kind of trying to do this work. And so like kind of doing collaborative care and being able to coordinate care is extremely important. And it can be difficult to find people because of the density of the city and where people may go and under bridges and in parks and in subways and places that it's hard to find. So I think that really that continuity and being able to connect with people, I find to be the most challenging for sure.
Definitely. And I guess I wonder, as someone who's interested in both the medical aspect of the work, and you mentioned lack of housing in the city, coordinating all these different teams, I wonder how you approach that balance of being involved. We all have a limited amount of time. And I think as a learner, it can be really exciting to enter different spaces of advocacy, of looking into housing policy, of all these different things. But also, for me, I'm in residency. For medical students and other people who are listening, we're all trying to really learn the medical knowledge that we need to be effective. And I guess I'm wondering if you ever kind of faced that struggle or that pull in your journey and how you thought about it.
Yeah, I think it happened kind of organically. Like I feel like when your voice is needed, you find a space to advocate, right? And sometimes that's just on an individual level, like so you'll find that, like working in a shelter. And I remember one of my patients when I was in one of the family shelters, she had diabetes and her blood sugar levels were always like super high, like over 500, like it always just said HI, every time we check on the glucometer. And, what she would tell me is like, she was like, Dr. Littleton, like I love my Coca-Cola. Like that's the only thing that comforts me living in this setting. And you cannot ask me to like give that up. Right. And so it was, a hard thing to work with, but like, talking to the people who offer the food and trying to work with them in terms of offering different options for her so that at least she could kind of reduce like the amount of carbohydrates that she was taking in or have more options for eating more vegetables or have more options for drinking more water. That individual advocacy of working with the dietary staff in the shelter can be tremendously helpful. So on that level, I found that there are avenues to do that. And then when there's larger issues you're seeing throughout all the shelters where clients are not being able to be offered harm reduction tools or being offered buprenorphine treatment or other medical treatment that will greatly benefit them, you start to more advocate on higher levels, And so I found that in my role, especially as the medical director of BronxWorks, I was able to speak, at city council meetings and other places to express what our clients need and what would help bring them better health. And so it was very fortunate because I was able to really be able to use a lot of my skills and work that I know from patients and the stories that they've told me and bring that to like a larger forum to help advocate.
Yeah, it's beautiful. It's almost like you were kind of like a vessel for the things that you were experiencing and got to share them with a broader audience. That kind of brings me to my next question. As you mentioned, harm reduction and buprenorphine and medication-assisted therapies and treatments, what the challenges are of bringing that treatment and that work into the street medicine setting. Obviously harm reduction is so central to our work in terms of getting people onto these therapies in a sustainable way. What has that looked like on the street and how has that evolved over time?
Yeah, no, it's definitely, the landscape has certainly vastly changed over time, right? Like I remember when I first got out of residency like 20 years ago, and that where like most of my patients were like in a methadone program, already hooked in, fairly doing well. And so when I got my waiver and was ready to, prescribe as much buprenorphine as I wanted, I really found it challenging in my shelter because a lot of the clients were like, no, I'm good. I'm in my methadone program and it's working for me. And I was like, okay, that's fine. And it was interesting. So I do that as part of my work. At about 2015, I kind of moved further upstate because of family things. So I started, the other part of my practice, I started working further upstate. And when I did that, I kind of took over this practice of a provider who, every person who would come in, they were like, oh, I'm just here for my like 100 Percocets and my 100 like Xanax. And I was like, I can't do that. And that's actually where I became more prolific in prescribing buprenorphine, like because where I was practicing was this remote clinic that didn't have access to any methadone clinics. Like the nearest one was like, 40 minutes away. And there was one bus that traveled, once a day there. So I was prescribing a lot of buprenorphine at the time and just realizing how life-changing it was for so many of my patients there. They would be like, oh my God, I'm able to go back to work. I'm able to connect with my family. I can go to a pharmacy and get it like a regular prescription. Like, I don't have to wait in line. And that's when it really occurred to me. I was like, why am I not offering this more to my patients in the Bronx? And so I really started to try to encourage a lot of my clients in the Bronx. Well, I know you've been on methadone and maybe that was working, but maybe you should try this. Like this might work better for you. And I realized when I was doing a lot of the street outreach that a lot of the limitations for a lot of our clients in terms of why they couldn't come in was really because they were still struggling deep in their addiction, right? And I felt like if we just get you on this medication and stabilize this aspect, then maybe you can start to pursue other things in terms of your housing and further on. So that's really when I started prescribing a lot. And there was a good period of time when it was great. We were getting so many clients on on and they were doing great. And then like about in 2017 or so, like fentanyl kind of infiltrated the heroin supply. And that really changed the landscape as well because it made it so much harder for individuals to get onto buprenorphine easily. Before that, they'd wait a couple of days and they could get on no problem. And then after that, they were just like, I've waited like 4 or 5 days and I'm still getting sick, And so it was a real big struggle. And I feel like we're still deep in that struggle in trying to get people on. And we've done microdosing, we've done macrodosing, and it's still, when someone's still, unstable living outdoors, it's really hard for them to follow some of those things and physically be sick, right? So we found that pretty challenging. And when we do prescribe for buprenorphine now, we realize it's very much a harm reduction tool, right? Like it's really something to help engage clients to kind of get them in. We realize they may be using it like half of the time, but that's like the times that they have it, or they're keeping safe from overdosing and dying and kind of living to get into housing and kind of furthering themselves in their recovery. So we've been kind of changing how we approach it and really using it in terms of all of the harm reduction tools that we do use to kind of keep people safe and giving them test strips and Narcan and all the other tools that they can use to be safe. But then also trying to get them in to housing because we understand that most people, it's like until they can have a safe place to stay, they really can't significantly work on their recovery. So we really try to use it as a tool to kind of help them get indoors. And it's a really great partnership that Care for the Homeless and BronxWorks have because BronxWorks helps with the housing and Care for the Homeless provides the medical. And so we can really work together to get people a little bit more stable so they can get to kind of that next step in their recovery. I'm really excited about the long-acting injectables. And so, certainly long-acting buprenorphine was something when I first heard it come to the market, I'm like, oh, this is fabulous. This is perfect for our clients. When the rubber meets the road, it's a little more difficult in terms of implementation, right? And I do have a few people who have started it. There's some glitches with just the pain of the administration, having enough out of their system to start it. But I'm hoping that it will be a way that people can switch over more easily to get on a medication that can really be helpful to them.
Has that been the primary kind of challenge there is like the kind of like washout period, or are there other challenges that you're also facing with the long-acting injectables?
That's part of it. I mean, insurance coverage, getting it delivered, finding patients, there's a lot of barriers for sure. But in my upstate practice as well, like I have a lot of patients who are on it and doing really well. And so I feel like if we can get kind of a good core amount of people who use it and do well with it, then I think it'll help take some of the fear. I think a lot of patients are so worried about getting precipitated withdrawal with it, that they don't even want to venture it, and finding ways to do it so that they can feel confident that that's not going to happen. I think it will be a major part of our step in getting a lot of more clients to utilize a valuable tool.
Yeah, and the other question I have is, I feel like even in my short time of training, I have heard the differences between micro dosing, macro dosing, and I'm wondering where your practice is at now in terms of what kind of ratio you feel like you're doing with either protocol or procedure, or if that's even how you're still approaching it.
Yeah, I think microdosing is very, very hard. Very, very hard for people who are unstably housed and have to try to follow some type of regimen. And even if you do kind of blister packing in terms of doing it, I think it's still extremely difficult. And like the buy-in of like, why would I do this when I could just take this and feel better quicker, right? Is difficult. So we haven't had a lot of uptake to the micro, but certainly the macro, I have had some clients who, when motivated enough, are willing to try. I found more success certainly with the macro dosing for sure.
Yeah, that's excellent. I often feel like the literature is trailing, especially in this field of harm reduction. And so I feel like, really connecting with other providers who are, on the streets doing the work and kind of understanding what's happening in real time is so important. I guess I'm also, I'm curious about, I'm hearing a lot of journeys that often take a lot of time, getting people into housing, macro inductions, all these things that we have to make so many contacts with our patients and really walk the journey with them. I'm really curious about you and for yourself, how you, view success in this work and how, medicine is so metric based, especially these days. And I'm curious more for yourself and how you kind of find meaning and keep going, keep inspired, like how you kind of view success and your work.
Yeah. You had mentioned earlier kind of what parts of my personality are kind of driven me to this work. And I think that definitely I am a perpetual optimist, which I think greatly helps. I definitely always see things as like half full. And so when I'm daunted with a task, I try to always look at kind of how it could be worse, right? And that's definitely helped me. I'm also a realist, I think, which really helps because I understand that given certain limitations and circumstances, like kind of what's the best way to approach something that makes sense, and I can connect with patients in a significant way with that approach. And I think in general believe like harm reduction is life, right? Like I think that everything we approach in this world is like, how can we reduce the harm that our environment is imposing on us, right? Whether that be if you have diabetes and you're eating a lot of candy, like everything, like it's kind of how I approach life. And so I think all of those things have really kind of helped me approach this work in this way. But I feel like with housing, for me, like what I find success is really getting people housed, like that to me is a major accomplishment. And like the housing first model, it exists for a reason. I think that it definitely housing very much is healthcare and can very much help people open the door to having better health. And when we can get someone into a stable place that they can call their own is really when they can kind of put their survival mode down and then start like working on things that might help better their health. And so for me, that is the biggest part of our success. I find that especially when people are living outdoors, we are very fortunate in New York City of having that shelter mandate to really be able to house most people in shelters. There's certainly caveats to that, and many shelters are congregate and unsafe in places that people prefer not to be. But I find that especially when you're working with people who are been chronically homeless and struggling, other housing options are much more amenable to. And so we found that a lot of times having either safe havens or stabilization beds where they have their own space and have much less rules and restrictions are things that are deal breakers or deal makers, right, for people who are living outdoors. And a lot of times when we're able to offer more of those options for people, they're much more willing to come in. So really being able to do that has helped, I think, the outreach that we've been able to do for people who are resistant to kind of that other shelter setting. And so those things I think have been tremendously helpful. I think being able to offer medical services for people regardless of their ability to pay and not have active insurance has also been tremendously helpful. And I think I've been really fortunate to work for Care for the Homeless, who has a great program for that and, has kind of federally funded money to support that, as well as for medications so that we can actually get people on medications even when their insurance isn't active. And certainly when people are struggling, it's important to be able to kind of get them the services they need when they need them, right? And taking away some of those barriers has really been able to greatly enhance the work that we've been able to do.
Absolutely. I'm wondering on that point if things have started to change or are changing at all with the current administration in terms of the support.
Yeah, great question. Yeah, I mean, they haven't changed yet, but we're very, very worried about where the future holds. I think that we are lucky to be in New York State and have a lot of support in our state for being able to provide this work, have the reserves and funding to try to offset some of that. But it's really a question of how long will that last and how long we'll be able to kind of continue doing that.
Absolutely. I often think about how lucky we are to practice here and to train here and to be often surrounded by people who have very similar mindsets and missions. Something that really struck me though in your last comment was about having the mindset of optimism. You kind of mentioned that you've been someone who's always like this, and I also feel like for me that almost feels like it's part of training is to train that muscle too of get the positive that we're doing here and not to undermine those little moments that I feel like can sometimes slip by us where patients voice their gratitude or you see a good outcome. And sometimes I feel like we have the mindset that this is just like another day, another moment of work. And I think it's been really helping me at least to kind of honor them and make sure that I allow those to take up as much space as maybe some of my worries do.
Yeah, for sure. And I think also just like training ourselves, which is hard in medicine too, because I think we are trained in a certain way to think about problems, but to try to sometimes think outside of the box, right? And think about like what's a different solution to this, which still could have a very good outcome, right? That we might not be thinking about. And I find that part of doing the work with stably housed people very interesting because I think it does challenge you to think about like the ways that we've always approached things and how we can look at it differently, but still have good outcomes.
Absolutely. That, really brings me to my next question, which is seeing as you do work with our trainees and do a lot of work to inspire the next generation, what lessons you want to impart that may not be included in our medical curriculum, whether it comes to working with this specific population or kind of just how you view medicine as a whole.
Yeah, I think the thing that I have always tried to implore in the students and residents I work with on the learners is really hearing patients, listening to your patients, and really being humble and empathetic in that approach. I think when you prejudge people based on certain activities or behaviors or things in their lives, you're going to make assumptions that are not correct, right? And really when you listen to patients and what they're saying, you will be more likely to come up with the correct answers and approach. I think it's very humbling being a doctor, and we don't, like we go to school and they're telling us that we should have all the answers, right? And then you start practicing and you realize you have none of the answers, right? A lot of the patients are the ones who have the answers, and I think really listening and valuing our patients' voice is so important. And I think when you can gain clients, patients' trust, you will be building so much of a stronger connection and path to health for them. And I always say that our patients are the drivers of the car, and we're really just in maybe the back seat, not even the seat across, right? And holding the map and trying to help them, they're the ultimate decision makers, and we're just trying to help guide them with whatever we know that might help them steer in the right path, right? So I try to encourage all learners to kind of take that approach when they're working with the patients that they're serving.
I love that. Yeah, we're along for the ride.
Yeah,
Yeah,
very
I think,
much.
especially being in this phase, I feel like we are trying so hard to develop confidence as learners. And sometimes I feel like, of course, it's important to have confidence, but I almost feel like, yeah, it's kind of that mentality of physicians know everything, we're in charge of the team. And I think that can really strip away humility at times, especially if you're not actively working to keep it at the core of your practice. And so I really value that message. Thank you so much. I feel like we've covered so much. I'm curious if you have any last thoughts or a story from a patient that has inspired you as of late, or a lesson that a patient has taught.
Okay, yeah. One of the stories that I always remember was in residency, actually. There was a patient that I had that was very heavy on using opiates and suffered from an opiate addiction. I mean, it's interesting kind of the path that my trajectory has been in medicine, because when I was trained, I mean, it was really where physicians were overprescribing opiates, right? Like it was like kind of the fifth vital sign, and we really overprescribed opiates for people who didn't necessarily need them, right? And I felt like this patient fit that bill, and she had come with low back pain, but by the time I got her, she was on fentanyl patches and on way more opiates than she needed, and struggled with that. And I remember she wanted to get she had already had her tubes tied. She already had like 4 kids, but she wanted to get pregnant. And she was like, Dr. Littleton, I want to get my tubes untied. I want to have a kid. And I was just like, what? Like, you can't, like, no, like, that's not a good idea. Like, I was like, my medical opinion is that would be a high risk situation, and I really discouraged her for the longest period of time. And then finally I kind of sat back and was like, wait a minute, Andrea, like, what is she saying to you? Right. And so I kind of reversed course and just supported her. And she ended up getting her tubes tied. We kind of got her on like a safe regimen of pain management. She ended up having a beautiful daughter. And I saw her for several years after that. And she was just like, thank you so much, Dr. Littleton, for believing in me and trusting me. And that always like rang to me, because I think it really helped me put my agenda on the back burner, right? And realize like our role as physicians is really to support our patients in their path, right? Whatever that path may be, and I feel like that is the approach that I use for my patients to this day. Not all patients are on this path of not using any substances at all, or even sometimes, being housed in where we want them to be, right? Like everybody has their own goals in life. And I feel like our roles as physicians is not to change that, but just to support them in that path and let them know kind of all the risks and benefits of that decision, right? So I always kind of remind myself of that story when I'm dealing with my patients who are really struggling and sometimes making decisions that I wouldn't necessarily make myself. And I kind of take a deep breath and I'm like, you know what? This is what I'm here for.
beautiful story. And people are people. And sometimes I feel like we forget that that's like the beautiful part of it too, right? Is that we're all
Exactly.
our own decisions and our own journeys, and how beautiful it is to be a tool on that journey, even
For
if, yeah,
sure.
even if there are decisions that maybe you wouldn't make, but so incredible to be able to witness.
Yeah.
Well, thank you so much for your time, Dr. Littleton. I'm so inspired by the work that you do. And I feel like, especially as things kind of evolve and change in administration, in medicine, I feel like some of these stories and lessons never really do change.
Yeah, and I feel like even though I think times are hard and they're gonna get harder, I think if we can kind of remember why we went into this field and like the important connections that we get with each other and with our patients, like we'll get through this, like there have been difficult times, before, and we'll get through this. And I hope we'll learn a lot from it, right? And have kind of safeguards put more into place so like we don't get to this place again, right?
Absolutely.
The Street Medicine Institute is a secular, nonpartisan organization. Any spiritual or political views shared by guests on Streetside are their own. They're offered in the spirit of conversation and should not be taken as reflecting the views or positions of the Street Medicine Institute. This podcast should not be used for personal medical guidance. Please consult your healthcare provider.